All right, let's get started. Hi, everybody. This is Psychiatry Grand Rounds. I'm standing in for Sharon Ron, who got called to court. I'm Jürgen Unitzer. I'm the department chair. I usually watch this from over at UWMC, and I know there are guys over there watching. Before we introduce our speaker, I want to introduce one other person, and that is Maureen Johnson. Maureen, can you stand up? Maureen has joined us in the department recently as our academic HR manager. We stole her away from the Department of Orthopedics, which I think is a great feat, and it's been fabulous working with her. So she deals with all of, every one of us goes through the academic HR office. So at some point, you will get to know Maureen, and she's fabulous. I just wanted you to know her. Great. And one of the first things she said to me, actually, when we talked in the interview, she says, I'd like to know what it's all about. So I want to go to the grand rounds. And I said, that's good, because that's not always true for people who are more of an admin role, so I think that's just great. So now it gives me great pleasure to introduce our grand round speaker for today, Dr. Ian Cook. You can see some things about him up here. I'm going to say some things that are a little bit more personal. Ian is a professor of psychiatry and bioengineering at UCLA. He does translational research, and he will talk to you about that, doing some really, really cool things in neuromodulation, one of a few psychiatrists who has a procedure. So by the time you all walk out of here, you're probably going to be very, very jealous of that. And does some very, very cool things that he'll talk to us about. He started out as an electrical engineer and a computer science person, trained at Princeton, did his medical school at Yale, and then residency in psychiatry at UCLA. Ian and I were residents together, and I could tell you some fun things about those days, but I probably shouldn't. He has actually kept pretty close in terms of his interest to the start that he had in electrical engineering and computer science. And when you get to the end of the presentation, you can probably still see the electrical engineer in this psychiatrist here. Ian has had a fabulous career. He's a professor at UCLA. He's over 100 peer-reviewed publications. But he also has more than 12 patents for devices and ideas and concepts and formulas that he's developed that actually help improve mental health. And he'll talk to us about that. What I've asked him to do in addition to giving us this talk is to talk with a couple of you and give me a bit of a sense of what we could do here at UW Psychiatry to kind of think a bit more about state-of-the-art neuromodulation treatments. I know we do a fair amount of ECT. We don't do much more than that right now, but we have, I think, great potential and some interest, and I've asked Ian to give me some advice on what we might do and how we might think about that area. So I think with that, I'm going to hand it off to Ian. Thank you very much for coming up. Welcome, and we all look forward to your presentation.
Great. Thank you. And thank you for not embarrassing me too much with tales of when I was young and foolish and had more hair. So, thank you all for coming. I'd like to speak about neuromodulation and sort of how does this fit into the present and I would say the future of psychiatry. Stay closer to the mic. Okay. So let me first start with the disclosure slide. Because I'm the inventor of one of these modalities, trigeminal nerve stimulation, I'm currently on a leave of absence from the university to serve in a role as chief medical officer of the company that is trying to bring this forward so that people can actually benefit from it. And I've also been the beneficiary of a lot of research support from the NIH and others. So why should we care about neuromodulation? Well, it's really driven by unmet medical needs, right? We have lots of patients for whom pharmacotherapy, for whom psychotherapy works wonders, which is great. But there's a large chunk of people for whom that doesn't work well. We learn that in STAR-D, we learn that in CATIE trials, we learn that in lots of very rigorous large N kinds of samples, as well as what we see every day in our practices. So we need to have something else, another arrow in our quiver, if you will. And here's where brain stimulation or neuromodulation therapies, I think, have great potential. I like to talk about it as being neuromodulation because brain stimulation sort of leaves you the impression that you're making things more active. And actually, it's much more nuanced than that. There are ways in which some circuits are being induced into a more active state, others are being turned down. And so I think neuromodulation captures that idea a little bit more crisply. A lot of the work has been done in neurological disorders. Some has been done in major depression, but there's some growing data in other areas too, which I think gives us all great excitement about the potential for this to be as revolutionary in some ways as was the advent of pharmacotherapy back in the 50s, 60s, and 70s. And as required by not only federal law, but also by CME rules, some of the things I'll be talking about don't have US approval by the FDA, and I will make that clear as we go along. So to anchor this in clinical experience, say you have a patient, Mr. A, in his late 40s, having a recurrence of MDD, and this time you've already tried SSRI monotherapy, because that's what his insurance insisted on, a switch to an SNRI, adding aripiprazole, off-label combination going back to the SNRI and bupropion, and then you throw in methylphenidate as well. And of course, each one of these iterations is eating up. No wonder you're so happy today. But alas, Mr. A is not so lucky. You know, this is the case for, unfortunately, a large number of patients. And because he's an exec in a company, he doesn't really want to even think about the possibility of having his short-term memory tweaked for a while when he's getting ECT. So besides more meds, what else could be added? So some of you have seen this picture before. This is not to suggest that pharmacotherapy is like ending up on the New Jersey Turnpike, although I did spend 4 years in that in the Garden State. It's really to capture the idea that people who are getting pharmacotherapy often feel that there are lots of different options, lots of different exits, but there's no roadmap to say what to try next. Sadly, the case all too often. So the themes to remember about neuromodulation is that this has really been facilitated by advances in neuroimaging and functional neuroanatomy. We probably couldn't have done this in the 60s and 70s because we didn't have the right tools to understand what the effects were that we were trying to make happen in the brain. The emphasis here is on circuits and systems, which again is asking us to think at a little bit different level than we're accustomed to, right? We're used to thinking about our meds acting at the level of synapse, at receptors, at that level of neurotransmission. Now, for this, we need to think a little bit one level up in complexity. Now, how the systems of neurons all work together as a team, if you will, or fail to in cases of illness. And so anatomy matters, physiology matters in a way that we haven't really demanded of our trainees and demanded of practitioners in the past. It's important to remember that this can change brain activity in ways that are different from what we could do with meds. So for example, you could change regional activity so that in some areas of the brain, activity goes up, and simultaneously in other parts of the brain, it goes down. I'll show you some actual PET scan data about that. Or as Holly Listenby likes to say, you know, you could hyperpolarize one part of a neuron and depolarize a different part of the same neuron. Very hard to imagine how you could do that with a lot of the other modalities that we have. So this is something a bit different from what we've been asked to think about before. And that, of course, is because the brain, this is Mark George's mantra, the brain is both electrical and chemical. And the last 6 decades we've focused very well, very thoroughly on the chemical part of the house. But now it's time to think about the other stuff as well. When a synaptic event happens, right, the neurotransmitters come across the synapse, but then once they bind and chemical cascades happen on the other side, what's the fundamental thing about the neurotransmission? It's the electrical signal that then goes down. So both things need to be valued. And much as for meds, we think about the molecular structure being the thing that governs what the biological activity will be. For neuromodulation therapies, we need to think about what are often labeled as stimulation parameters. I'll put some of them up here. Things like anatomy. Where are you trying in the brain to stimulate? Right? With our medications, the molecules go everywhere. So if there's something that it will bind to, whether it's an intended target or an inadvertent target, it'll bind and cause an effect. Here, you actually can, to some extent, focus where you're causing the action to happen. Is it right? Is it left-sided? Is it bilateral? How big a target are you looking at? Very small in the case of DBS, or very broad in the case of some of the transcranial magnetic stimulation modalities, or TMS. And then things about the signal, the active ingredient, if you will. What is its waveform? How fast are the pulses coming? If there's a pulse that's part of this, how wide are the pulses? How strong are the pulses? various things. And in some ways, this is like thinking, okay, where are the methyl groups? Where are the cyclic structures in a molecule? And how does this impact upon what will happen biologically when this is introduced into a patient? Conceptually, when it comes to the therapies, I think it's useful to divide things into those that are convulsive and those that are not. And in particular, we'll focus today, because it's a long, long list of things. The ones with the asterisk are the ones that have FDA approval for depression. We're going to focus not on everything, but just on a subset, on deep brain stimulation, because that's gotten a great deal of popular press as well as interesting scientific reports. TMS, transcranial magnetic stimulation, and then a newcomer, trigeminal nerve stimulation, because I think that has a different role in how these therapies may actually be introduced into the clinical arena. So the FDA, again, DBS is approved in neurological disorders like Parkinson's and tremor. You can all go online and see some really amazing videos on YouTube showing people with a stimulator turned on, and all of a sudden the tremor stops. It's very dramatic. Wish it were quite that dramatic in some of our psychiatric disorders. Refractory OCD has a approval from the FDA under what's called a humanitarian use device exemption. But its use in MDD is still experimental. TMS, there are two devices that have been approved in the United States for use in depression, one from a company called Neuronetics, one from a company called Brainsway. And then TNS, the one of which has come out of UCLA, is still investigational across all indications in the US, although it is approved for use clinically in some other countries. So let's talk first about DBS, because this is really at one end of the spectrum. It's very focused in terms of anatomy. It's very high-tech. It's also very invasive. It's brain surgery. 9 years ago tomorrow, that august medical journal, the Wall Street Journal, ran this article illustrating that indeed, yeah, sometimes the lay press gets it wrong. There's no shock. We're not shocking the brain with DBS. But this really is when things start to become very focused in the lay press. A lot of expectations start to develop, in part because at this point it had already been approved for Parkinson's, it had already been approved for tremor, and now the idea that we could have a therapy that was procedure-based, that involved a device, that didn't have the kinds of side effects as we have with medications, was very interesting and appealing to not just the scientific community, not just patients, but also to these people called investors who read the Wall Street Journal. So DBS in depression, many of the early reports came out of the work of Helen Mayberg, who then was at Rotman and is now at Emory, and Ben Greenberg at Butler and Brown University. The central mechanism of action here, the concept is that you're trying to interfere with circuit pathways that are dysfunctional, a jamming signal, if you will. You're trying to interrupt what these circuits are doing because they're doing the wrong thing. And to that end, one of the targets, this is Helen Mayberg's initial target, the subgenual cingulate, in particular the white matter tracks that are in Brodmann area 25. And this she honed in on really because a lot of research before had shown that the gray matter in this area, this part of the brain, has decreased activity when you treat people with SSRIs, with ECT, with TMS, with ablative surgery. And so, gosh, here's maybe a way that it could be affected in a way that can be delivered around the clock, because the implanted device can be set to go on as many minutes during the day as one wishes. But that's not the only target. A lot of the other targets here, let me move on to the next slide actually. They're all, as you can see in that diagram, they're pretty much all in the limbic system, which would make sense if you're trying to affect a mood disorder, right? And there are data to support the potential clinical benefit from stimulation of the DBS target in any of these areas. Probably the most studied target has been the Area 25 target. And this report out of Andres Lozano's, he was the first author, Helen was the second author, included an N of 20, so the 6 that were part of her original 2005 report, and then 14 more. It's an open trial, and these people were pretty darn ill. They didn't report the so-called the ATHF, the Antidepressant Treatment History Form Index. For those of you who don't live with quantitating treatment resistance and depression all the time, it's basically a schema that had been devised by Harold Sackheim and others at Columbia to quantify how many medications had been given a real honest-to-goodness try at an adequate dose for an adequate duration before you moved on to the next thing. And of course, in clinical practice, do we inflict 4 to 6 weeks at a full dose on everybody before we say this is not working for you? Anyone do that? Some people. Not. It's usually there are other reasons why a trial may be shortened. But in the research world, this is sort of the gold standard for saying how resistant is a person to pharmacotherapy. And but these people were on an average of 4.2 medications at the time that they were being implanted. So if you think of what it takes to get to being on a combo of 4+ meds, they have been through an awful lot. The responder rate at 1 month was 35% in these very ill people. 10% were in remission. And again, think about in your own practice the number of people who you have who have gotten to be on a combo of 4 different meds and how ill they are, and how amazing it would be if even 1 in 10 of them made it into remission at 1 month. Pretty cool. At 6 months, 35% remission rate. So again, very encouraging, and I applaud, well, I didn't applaud, Lozano applauded, this is from his paper, showing there the time course over time. And of course, the responder rate and the remission rate goes up and is reasonably stable there. One of the challenges, though, is that 13 of those 20 people had some kind of adverse event, ranging from perioperative seizure to wound infection requiring hardware removal. So there are still a lot of technical challenges to make this sort of thing as useful as it potentially could be. But there's still great promise. There's still a lot of excitement because of the notion of the precision with which this therapy can be delivered. When you look at the data overall, you look at all the trials as of early this year, when we wrote this paper about DBS and depression. The thing that always strikes me is the sample sizes. You've got one trial of 21 people, and everything else is smaller. Now, some of this is because it's very challenging to run a trial with perhaps one of the most invasive kinds of surgery that one can do. Brain surgery is pretty darn invasive, most people would acknowledge. And getting consent to do that kind of a thing makes it very hard to do a sham-controlled trial. St. Jude Medical had licensed the patents out of Helen Mayberg's group and ran what was called the Broadman trial. Broadman Area 25 Deep Brain Neuromodulation is what it's sort of an acronym for. And unfortunately, back in late 2013, this trial was stopped for what's called a futility analysis. Basically, that a statistical analysis performed, and if the trial cannot meet its endpoint within the allotted number of subjects that have been projected, the sponsor has the ability to stop the trial. That's what they did. They stopped enrollment. They're still following the people who got implanted, for a number of for a long time to come, but they just stopped enrolling. So this puts the future of DBS in alas, a bit of an unknown state as to what will happen next. Of DBS companies, St. Jude is one of them. Medtronic is also one of the entities working in this area. Boston Scientific and a few companies, small companies in Europe have DBS systems. But what will happen in depression with DBS, I think, still remains to be seen. This was a big blow to the DBS niche when this happened last year. This is the big trial on which a lot of hopes have been pinned. So let's move on for a second now to transcranial magnetic stimulation, which does have FDA approval. As Mark George likes to say, and this is actually one of his images, this is not Mark. This is Sylvanus Thompson, but Mark has a mustache of equal distinction. People have been working, trying to stimulate the brain with magnetic fields for a long time. But really the current era begins, I think most people would say, in about the mid-'80s, when Anthony Barker and others in England were working on stimulating the motor cortex with pulse magnetic fields in order to have a neurodiagnostic tool, something where you can do an electromyograph where you stimulate in the periphery and then measure the brain's response. Well, this measures the outflow tracts. You can stimulate the motor cortex here and see if you get a motor response, and so you can probe the outflow tracts as well. In the mid-'90s is when people started thinking, maybe there's a therapeutic use here, because maybe we can turn on some neuroplasticity. Maybe we can change how brain circuits are functioning in a way that could be therapeutic. And Mark George, working at the NIMH, and then others working at Bonn, published almost simultaneously some exciting work in this area. The central idea across all of this is that a time-varying magnetic field, changing magnetic field, will induce an electric current in brain tissue. So this is different from the magnets that people may put under their mattresses, where, unless you're moving around an awful lot in bed, it's not a time-varying magnetic field. Those are static magnets. It's basically a static magnetic field. Here, the whole thing is that the idea is that the current flows in the brain because the magnetic field is changing. And at the risk of invoking some PTSD for those of you who will remember the right-hand rule from college physics about the way that the magnetic field curls around and which way the current flows as a result. This is the fundamental principle that this is all based upon. And again, coming back to the notion, it's an electrochemical organ. So when the neurons are stimulated, they don't, in some ways, they're agnostic to what's causing them to be stimulated. That's a little bit oversimplification, but to a first approximation, that's true, because what happens is that the pulsed magnetic field induces an electric current, which depolarizes neurons in the cortex. That produces action potentials, and at the other end of that neuron, then there's a release of neurotransmitters. And a cascade of events happens that we'll look at in just a second. Some of you will recognize the gentleman there on the upper left. Didn't know you were going to be here, Dave, so hope that's your good side. TMS has the technology has moved along a bit over the past few decades. It used to be said that you weren't really a veteran of TMS unless you'd had at least one machine explode, because a lot of these things use water cooling to cool the device, and as you know, water and electricity don't always play well together. The current systems look more like in the lower left and there on the right, where there's a coil that's in something that can be held or positioned on a mechanical arm over the target in the brain, and the magnetic field, then shown as those blue waves emanating there, will come through the skull, because again, the skull is not ferromagnetic for most of us, and so the magnetic field passes unimpeded into the brain tissue and can induce its electric field there. A few concepts, a few terms to know, because this is how people talk about the differences of different kinds of TMS stimulation. So there's a pulse. The current flows through the wire into that coil, makes a brief magnetic field appear and then disappear. You can bunch a series of pulses together into what's called a pulse train, and those have a characteristic frequency at which they're pulsed. So, for example, 10 pulses per second, and a certain duration. In this case, one second. In clinical practice, one of the most studied paradigms involves pulsing at 10 pulses per second for a 4-second period, and then it's off for 26 seconds. And then the cycle repeats again and again and again. So you get out typically to 3,000 pulses in a treatment session. Lasts about 38 minutes. And that's how long the person is sitting there in the treatment chair getting the stimulation happening, during which time they're awake, they're alert, they can be talking, they can be reading, they can be watching TV. They can be doing psychotherapy. Lots of things are possible. Unlike, say, ECT, where people are under general anesthetic briefly. So it's a different kind of experience. And after they get up, they feel okay. They drive on to work or drive home without impairment. So this is sort of how a treatment session is built up of these constituent elements. One of the other key concepts is detecting how strong should it be and where should I point the magnet in this person, because everyone's a little bit different. When we first got our system at UCLA, it would have been unethical for me to ask for my staff to volunteer to have their motor thresholds measured. So I got to sit in the chair and be the crash test dummy for all of my staff to practice on. And we learned, and no surprise to some of my colleagues, that I have a rather thick skull, thick skin to match, since I've been in academia for so long. But the impact of this is that if you have a thicker skull, your brain tissue is farther away from the magnet. And so since the magnetic field strength falls off as a square of the distance, even a few millimeters of difference can mean a lot of reduction in the magnetic field strength. So you have to measure it for each person, because everyone's skull is a little bit different. Because also things like medications like anticonvulsants or benzodiazepines that can change cortical excitability also impact upon this. But you first measure to find out how strong it should be by aiming for this nice big target, the thumb part. Now, when I started in psychiatry, I did not think I would be living with the homunculus every day that I'm going to clinical practice, but in fact, this is what I do at the first session. I had to find where in the brain to stimulate, so I find the motor cortex by finding the part that controls the thumb, and then looking for when does the hand twitch. And then we do go through a series of exercises to see how strong should the field be, so that we get a twitch 50% of the time. And then the actual treatment target is about 5.5 centimeters forward of that. Now, you will no doubt say, well, gosh, some people have bigger heads and some people have smaller heads. And why would you use the same distance for everybody? Well, this is not quite laser precision targeting. You actually stimulate a reasonably large, much larger than DBS kind of area. It's not the whole hemisphere, but it's certainly not a pinpoint kind of chunk of brain that you're stimulating. And so in clinical practice, it seems that this works very, very well for most people. And it certainly is a lot easier and less burden cost radiation exposure than a lot of other methods that have been examined. So that's the FDA blessed way to find the target. So back to the biology. What happens? So the magnetic field pulses. It induces a current. The superficial cortical neurons depolarize. But they're part of a circuit. And everybody else in the circuit is also apt to depolarize. And so this changes the activity throughout. Shown there in the bottom right is a SPECT study comparing before and after a course of treatment for a series of in this case, 12 adults who had depression were being treated with TMS. And you'll see that under where the magnet is placed, there are changes in activity, but also deep down, other parts of the limbic system that are connected. So again, this is why it's important to think about it as really a circuit level or system level kind of change that's elicited. And the bottom line is that in animal studies and human studies, there have been changes in things like salivary cortisol and monoamine concentrations in spinal fluid samples. In animal models, BDNF genes are turned on. But the bottom line, I think, from a clinician standpoint, is that what matters most is that when you stimulate over the target, the dorsolateral prefrontal cortex, you can affect cingulate activity and other limbic structures. Okay, as you can see from the list there, a well-replicated kind of finding. When it comes to clinical data, it's useful to think about this in some ways in terms of two eras, if you will. In the early days, from 1995 until about 2003, lots of people tried this all over the world. And they tried it in all kinds of different ways. They tried it just for a few days. They tried it for a couple weeks. They tried it on the right, on the left. Different targets, different signal strengths, different numbers of pulses, different frequencies of, all those many parameters that can be varied. Someone probably looked at it in a lot of very small sample kinds of trials. And so the literature is, I think, most constructively thought of as being kind of a dose-finding exercise. If you thought about and the reason I say it that way is because a lot of the pushback when this first became available in the United States was that, oh, this doesn't work. Look at all these studies from the 90s and the early 2000s that couldn't find a consistent signal. Well, yeah, if you did a bunch of studies of a molecule called fluoxetine, dosed 10 milligrams a day, you might have given up. Lilly didn't. Prozac helped a huge number of people, made a few $billion for some folks too. It's a dose-finding exercise, that era. Because when you look at what happened after that, when people started to move away from underpowered studies to things that were adequately powered, to controlled studies, to more focused, consistent kinds of things, the sort of the 2005 and after, the story became much more consistent. And in fact, if you look at things like effect size across studies and meta-analyses, it's twice as big once people got it right than in the early days when they were hunting around to see what was the right way. And of course, the reality of this is that it is an infinite parameter space, right? You've got lots of different frequencies, lots of different targets, lots of different field strengths, lots of different pulse widths. It's a multidimensional nightmare as far as trying to find out what's optimal. So a better idea is to try what works a lot of the time as a starting point. And it can be refined later, but I think that's where things are. And if you look at the Cochrane reviews as well, things that looked only at the early literature, present a rather unclear picture. The more recent data suggests it's more consistent. So one of the first big trials was the Neuronetics FDA Registration Trial to bring this to market. 301 evaluable people, all with unipolar major depression, non-psychotic, and these kind of treatment clinical parameters. They had to be medication-free during the 6-week trial. So it was a monotherapy. It was sham controlled. Everyone sat in the device, sat under the magnet. The people who got the sham condition, there was as I understand, a piece of special permittivity metal that was placed between the actual coil and the brain to prevent the magnetic field from penetrating at its full strength. They got what has become sort of the standard formulation, left dorsolateral prefrontal cortex for the target, so-called fast pulsing, 10 pulses per second, 3,000 pulses per session, at 120% of the field strength that would lead to depolarizing of neurons in the motor strip. And at the end, the people were then tapered from doing it 5 days a week to 3 days a week to 2 days a week once, and then entered a 6-month follow-up study to see what would happen, where they were actually all started on monotherapy with a medication, patient and doctor choice. And these are the results that were published. This is looking at people who had only failed to benefit from one medication, because this was their initial indication, because this is where the signal was most clearly detectable for the FDA's purposes. But as early as week 2, people are starting to feel better. It tends to persist, get a bit better over weeks 4 and 6, and so very encouraging data. It led to the FDA approving the first device to come on the market for this. And just to give you a benchmark, and again, it's not in my disclosure slide, but I was part of the study. I won't say the mafia, but exactly, but I was part of that study at the UCLA site. And we learned a lot. Not exactly what we had perhaps set out to learn, but an awful lot of things that are useful. And so here on the left, we have the 4 levels of STAR-D, right? So people came in, level 1 was citalopram monotherapy. Level 2, they could either switch or augment. Level 3, more complex. Level 4, more complex. Level 1 is like ATHF 0, right? You haven't failed the medication yet. So level 2 is like ATHF 1, people who have failed a round of monotherapy and are now trying something second. ATHF 2, people who have failed 2 rounds of pharmacotherapy. So just to give you a sense, this is what we found in STAR-D as far as remission rates. This is what was found in the Neuronetics trial as far as remission rates. And so clearly it works better earlier on in the treatment paradigm, as do our meds, as do most of our therapies. Or to state the obvious, people who are hard to treat are, alas, hard to treat. And that seems to hold out for this. But it's certainly in the same ballpark as some of our best pharmacotherapy. Holly Listenby and others reported an exercise to see, well, if we can figure out who to use this therapy with, wouldn't that be great? And so they looked at all the usual suspects: age, gender, treatment resistance in the current episode, lifetime duration, all these things. The only thing that's popped out statistically significant as a predictor of outcome was the number of medications that had been failed in the current episode. And so initially on, when this first came out, people really used it very much within label. People who had only done well, only failed to do well with 1 round of pharmacotherapy. But again, how many people don't get well with the first SRI they try, and then they think, gosh, I didn't do well with that. I'd like to try neuromodulation. It's not the way that the field thinks about things. And so a lot of the early clinical use was actually people a bit off-label who were far more ill. But that's okay. We'll come back to that in a second. It's always good to have one trial, but industry-sponsored trials are, of course, industry-sponsored trials have to be taken with the appropriate calibration and grain of salt. The NIMH funded Mark George and others to do an independent trial called OpTMS for optimizing TMS. They used the same target. They used active condition. They used a very elaborate sham, because at this point people could read online in blogs and elsewhere about when you were getting stimulated, it felt like there was a woodpecker tapping on your head. This is verbatim what many patients describe. There's a sensation, and whether it's the thought is that the magnetic field that is making your brain have a current is also inducing a current in the soft tissue of your scalp, and there's muscle there, and it twitches, and it feels. I can tell you, I've had it done. It feels for all the world like something is tapping on your head. It's not painful. It's not noxious. It's more weird than anything else, I think. It's kind of like if you have a rubber band and snap it on your hand. It's that kind of a sharp, percussive kind of a feel. And so they simulated this experience by having actual electrodes placed on the surface of the scalp, and they would pulse a current through there so that the person would have the muscle twitch, have the sensory experience, and this really helped with the blind. People really couldn't figure out whether they were in the sham or the active group in this study. They went 3 weeks to the primary endpoint under double-blind conditions, and then people could have 3 more weeks, the same of whatever they were getting if they were better, or switch to open-label active for sure if they were not. In their intent to treat sample of 190 people, their 3-week remission rates were 14.1 versus 5.1 in the sham. Significant, clearly, an NNT, number needed to treat of 12. But again, 14% remission rate, even under very rigorous conditions, is not something that is necessarily going to change the paradigm. They did find, however, that if you go out to 6 weeks, there you get a remission rate of around 30%. So probably 3 weeks is just too short of amount of time. It's just not enough exposure to this for your average person. There's procedure envy. There's also, I think, ECT envy, where people want something that works fast. Because, of course, who wouldn't want a treatment that works fast for our patients? Anyway, as a result of these and other trials, the Canadians got this into their practice guidelines. TMS has level 1 evidence to support acute efficacy in depression. VNS is below there. ECT is clearly above. It's certainly still the gold standard. DBS investigational. By 2010, the APA practice guidelines have been revised to include this as well. Again, in the hierarchy there. And then in 2011, the AHRQ commissioned a report to look at all non-pharmacologic therapies for treatment-resistant depression in adults. And they found here, I would direct you over to the right-handmost column, it was better than sham with high or moderate levels of evidence across the different kinds of outcome that you're looking at. So really solid, an emerging solid database saying that this is a treatment, bona fide treatment, it works, and can be really quite transformative for a lot of patients. Where does this fit in the treatment algorithm? Well, based upon the data, right now, if a person doesn't get well with their first-line treatment, many people will switch, then move on to augmentation, adding in a number of things. The data with TMS suggests that if you have people get well with TMS, then you can probably maintain them on monotherapy afterwards. And in fact, this is what some of the longer-term follow-up studies suggested, that in some ways people have, this may overreach what the data can support, but some people have suggested that maybe the brain has actually changed in some way as a result of this experience with TMS, that now it will respond to monotherapy where in the past it hadn't been able to. That clearly needs to be confirmed by some more studies before we can say that with any certainty, but it's an interesting kind of observation and a hypothesis to test. In the real world, we often think that, well, when I was a medical student, one of my epidemiology professors said, you want to be sure to get that cancer chemotherapy early on before people know that it doesn't work in broad samples. There are challenges when you disseminate a treatment from a rarefied group of academic centers who spend a lot of time living and breathing this stuff to a wider range of groups. And so we were actually part of this trial, multi-site naturalistic clinical use. 76% of the centers that contributed data were in private practice. Only 17% were in academic medical centers. The rest were various kinds of institutions. 307 people, mostly women, mean ATHF of 2.5, so a more ill group than in their registration study, and yet, here's the Kaplan-Meier curve, depending upon which metric you use, you get about half the people meeting responder criteria and about a third being in remission over the course of treatment. It typically takes about 28, so again, 3 weeks, 15 treatments, probably not enough. In the real world where people can dose it as makes sense for in response to how people are getting well. And of course, these are folks who are having periodic rating scales administered to them. So you actually have numerical data to go on to say, is this person getting better? Should I do something differently? You can measure this, and this is sort of the thing that's happening. This is borne out. Our experience at UCLA is very much like this. That about half the people get significant benefit, are responders, and about a third of the people make it to remission. Maybe a little bit higher now. Importantly, this was primarily adjunctive use. So the registration trials were as a standalone therapy, monotherapy. Here, patients who have TRD often are hesitant to give up medications, even though they may hate the side effects. even though they may not be at all pleased that they're having some kind of response, but there's a certain level of apprehension that people have about abandoning something that has gotten them to whatever state of partial wellness they're in. And I think this has been my own clinical experience. Many of you may have sort of a similar experience whenever you're talking about a medication change. Giving up something that may be not working well, but maybe helping some, is a tough call for a lot of patients. So in the real world of practice, many people actually say, no, add this, don't substitute. And then once they're well, then we have the discussion of, often initiated by the patient, of, okay, what meds can I get rid of? And then picking the one with the most burdensome side effects is often the treatment algorithm pursued. So in the context, depression and other disorders, on-label use really still is monotherapy. Everything else is a research focus, or although people do it in clinical practice all the time. Treating bipolar depression, the need is very, very clear, because we don't do as well with pharmacotherapy in the depressed phase of bipolar disorder as we do with the manic phases. But we still need more data there. There's some encouraging data in PTSD. It's being used for med-refractory auditory hallucinations, for tinnitus, for nicotine addiction. So there are a lot of people looking at this in a research setting. There are even more people who are using this without a whole lot of research base in clinical practice because they can, and there are patients who are asking for it. Again, the worst side effect that happens most of the time is that people feel this tapping sensation in their head. There is a rare risk of a seizure event being provoked because you are exciting the cortex, and it has been reported with all the devices that are currently on the market that it's a risk, but it's a very, very low risk. Some people have said it's less than the risk of a seizure from Wellbutrin use. What else is there? The second device in the market is this one. It uses a different geometry for the coil to stimulate deeper into the brain. They have very comparable or encouraging results from their pivotal trial, and the FDA has approved them as of January of 2013. We're still waiting to see the peer-reviewed publication of their pivotal trial results, so a lot of the nuances may become clearer once that is actually out there in publication. Deng and others at Duke in Holly Lissinsby group did this kind of quantitative engineering analysis, looking at the actual fields that are produced by a wide variety of coil geometries, because again, you can play with the magnetic field in a lot of different ways. And of course, the trouble is that if you're going to be able to stimulate deeper, you're probably not going to be able to focus it as well. And so you're going to be stimulating a bigger chunk of brain deep inside, with the possibilities for that being either good or not so good. Other things in the pipeline, a company called Cervell, spun out of Stanford, has developed a multiple coil kind of TMS where you pulse the coils in sequence to generate a more complex geometry for the field deep inside the brain. They're pursuing this right now, both in depression and in fibromyalgia. A trial that we were involved with at UCLA uses so-called synchronized TMS. This, rather than having a magnetic field that's generated by a large current flowing through an electromagnet, here there are these three permanent magnets that are in the machine that spin and generate a time-varying magnetic field that way. They spin pretty fast, and they spin at a rate that's timed to synchronize with the person's own individual alpha rate, their own alpha rhythm. Because there are some data to suggest that you can entrain brain rhythms this way and get benefits with a much lower field strength magnetic field. In fact, this device is not strong enough to actually make neurons depolarize. But there's a pivotal trial that's been completed and hopefully will be published soon. And then we'll hear about the regulatory situation for this one. But this is another device that's out there. Because this doesn't have the liability of evoking a seizure, one doesn't need to have a physician there for safety reasons in the way that one does for the other kinds of pulsed magnetic fields. And so this is now a therapy that could be deployed in a different way than one that requires a procedure with a doctor there. The group at McLean has also looked at this question of very low fields, because there were anecdotal reports of people feeling better after they had MRI scanning. And some of it may be imaginary, but some of it may be real. And so they did a series of studies looking at this, both in animals, found changes in brain activity that were suggestive of things that you would want to see in someone getting well from depression. And they've now moved it on to some clinical trials, which have been very encouraging. That far more people in the active group got improvement than in the sham group, and not too much happened in the healthy controls. So it's not, again, whenever you worry about this, when you think about ketamine and other kinds of medications that are being examined, is it just that people get high and feel better, or is it something that's more profound than that? And this seems to be more profound than that. So finally, in the last minutes, let me talk just a little bit about TNS. And here, the trigeminal nerve, we don't, again, I didn't think I would care about the homunculus when I entered psychiatry. I certainly didn't think I was going to care about that much about the trigeminal nerve. But it's there. It's the primary sensory nerve in the facial structures. So in animals, whiskers are part of the trigeminal system. And if you think about how small foraging animals learn about their environment, right? A lot of it is because they're touching things with their whiskers. They're figuring out, where's the food, where's the foe, where's the mate. A lot of very important survival information actually comes in on this pathway. And this may be why it's the fattest trigeminal nerve. It's the highest bandwidth pathway in. And it happens to connect to all these areas of interest to psychiatrists and neurologists, right? Locus ceruleus, the Raphe nuclei, the insula, the anterior cingulate, areas that we care about a lot. And in fact, if you look, and some of you will know about a therapy that has more use in epilepsy than it does in mood disorders, called vagus nerve stimulation. The vagus nerve hooks into the brainstem at the nucleus tractus solitarius, NTS. The trigeminal nerve has a somewhat broader array of projections into the system. And so these then allow, I would suggest, modulatory influence over a large number of CNS structures. And so we did an O15 PET perfusion study looking at what happens when the device is turned on. And as I had alluded to earlier, you can get things that are hard to imagine how you would get with single agent pharmacotherapy, where we have probably important for the epilepsy mechanism of action. We have in this bottom frame areas where blood flow significantly and robustly went down within seconds of the device being turned on. Areas like the primary motor sensory area, target engagement, but also turning down the gain in the areas that would be involved in the spread of an epileptic seizure. So you stop the spread of the electrical waves so it doesn't become a full-blown motor seizure. But from a psychiatric standpoint, gosh, here we've got the anterior cingulate, we've got the medial frontal cortex, we've got the orbitofrontal cortex, all showing changes in blood flow within seconds of the device being turned on. So very exciting stuff. My colleagues who started this, and then I joined in the group, started with treatment of drug-resistant epilepsy. Their analog big problem, like treatment-resistant depression, is for us. They found very encouraging early results, 42% responder rate in their initial trial. They did a second trial, double-blind controlled trial. I won't spend time on the epilepsy findings because the cool stuff for us in this discussion is what happened on mood. So under double-blind conditions, twice as much improvement on the Beck Depression Inventory than in people getting the control condition. The control condition was the same stimulator, but set to give pulses at a very slow rate, just 2 per second instead of 120. So again, pulse frequency may be very critical for some of the stuff. This led us to do a study at UCLA looking at a proof of concept trial, 11 people with reasonably bad TRD. They all had to have an ATHF of greater than 1, but in reality they had a median of 4 and a mean of 5.2. Pretty ill group, as you can see from their depression severity there. They came in, they used the device every night at home, and we saw them every 2 weeks to rate how things were going. And again, we used actually 4 rating scales because at that point we didn't know what was the best yardstick to use. All 11 completed the trial, and the worst side effect that we saw was rare evenings of skin irritation, which we've now subsequently addressed with an improved electrode patch. This is what it looks like. Looks like kind of like the device is like a big cell phone. The next generation will be a lot smaller. And you put the patch on at home at night while you sleep. You just to a comfortable level where you can feel a little bit of tingling in your forehead. That's about it. And here are the results. Big percentage changes across the board, very large effect sizes. But I think even more interesting is the time course graph. Whereas early as week 2, we're already seeing across all 4 measures a significant decrease in symptom severity. And I would, at the terminal visit, week 8, 7 of the 11 were responders, 4 of the 11 were remitters, 36%. And if you think back to STAR-D, that maxed out at ATHF 3, because people went through 4 levels of treatment to get to the very end. Here are people who were even more ill. we're having a better responder rate. So again, small study, open condition, open label condition, always a very interesting but tentative starting point. So now there is a dose finding study, double-blind study going on at UCLA now that hopefully will have the data set unblinded later this calendar year to look at this in a more rigorous way. It's not just symptom benefit, it's also translating to actual quality of life improvement, comparing before and after the 8-week course. And now there's independent replication. A group in Brazil studied 11 subjects, used basically the same treatment parameters, but there they only gave it to them for 30 minutes a day for 2 weeks, so much smaller dose. And there they got even better results than we did, which is interesting. And of course, the challenge here is that it's a very brief trial, 2 weeks. And if you think about the ketamine trials, you get an acute response, but then it wears off. It's not clear from any of this data how durable the treatment will be. And that's the subject of some of the other investigations. But always good if not just you think your baby is cute, but someone else says your baby is cute too. So independent replication is really quite essential. We also, because we saw benefits in anxiety subscales, because we saw benefits in sleep patterns, we also did an open label trial in PTSD. People who had been ill a median of 37 years from the time of their trauma, a mix of combat and civilian trauma. And again, in the interest of time, I will just touch very briefly on the fact that both PTSD scale and depression scale showed a significant improvement. There's now a phase 2 study starting at UCLA that the Army, the DoD, is funding. So we'll have some double-blind RCT data about that soon. And we also did a phase 1 study in depression and ADHD, because again, if you think about the circuits that are involved in controlling attention and behavior, that's where a PET scan would suggest that there could be some benefit. Jim McGuff, our psychopharm maven at UCLA for ADHD, did this. He wanted to do it not as an adjunctive therapy like everything else that I've shown you so far, but as a monotherapy, as an alternative to using psychostimulants because of the side effect profile. 20 kids, as young as 7, who did this. Improvements both in the inattentive subscale, the hyperactive impulsive subscale of the ADHD rating scale, in a effect size that's very similar to what you would see with the best psychopharm treatment, sustained out at week 8, and also importantly on more objective measures like computerized measures of reaction time and working memory, a significant benefit. So now the NIMH has funded him with a perfect score of 10 on his R34 grant to do a double-blind controlled study of this, and that's going to be starting next month. So just to sum up, clearly we need alternative treatments. We need more arrows in our quiver to take care of our patients because many of them do get better with what we can offer them now, but many of them don't. And I would suggest to you that there are a lot of novel neuromodulation therapies that are either on the market now or that will be developed soon for clinical use that we need to pay attention to. And in the meantime, ECT is still the gold standard for many patients who can benefit from that modality. Just as a comparison, in 2008, there were no FDA-approved TMS systems in the United States. Now there are over 500, so it's still on an inflection going up as people realize this is a very useful therapy for many people. So with that, let me stop and take any questions. Thank you. 4, 2, 1 second. Okay. Questions? Yes. John.
I was wondering about side effects with the Trigeminal and also whether that an application for migraines.
Sure. So questions about the side effects. The worst side effect that we have seen has been the skin irritation. And actually that was with the early generation gel and geometry of the electrode. We've now refined that. Less than 1% of the nights of use now have that problem. Also in the early trials, there was some people who reported increases in anxiety and of anxiety and headache. It turns out that there are some people who have this idea that if some is good, more is better. And the early device, you could crank up the current to higher levels than what had been recommended. And those are the people who had those side effects. So those are reported as side effects. The current version of the device has current limiters in it to prevent people from doing that, much as you wouldn't want people to take 4 times the dose of a medication. Migraines, we don't have data in that yet. I think it's covered in the patents. And there are good reasons to think why the circuitry ought to have impact on that. Again, only so many clinical questions you can address it at any given time.
Patients in your depression studies who have headache?
There were some who had headaches, but not migraine, and the headaches did get better. Other questions? Yes.
You listed tinnitus as one of the areas that might have had some improvement. Was there any either work you did or other that you know of that tinnitus has helped?
Sure. So tinnitus is something where there are some mostly open studies of its use with TMS, and most of them suggest that there's some benefit. Usually the target is over Heschel's gyrus, over auditory cortex, and one typically uses the slow pulses, the inhibitory ones, to try to turn down the activity in that area, if you will. But as far as how big the effect size is, there's not enough data to really to say that yet. As academics always say, more work is needed. So, any other questions? Okay. Thank you very much.